lecture 52 of iFocus. Today we have Dr. Umang Mathur from Shroff Charitable Eye Hospital, New Delhi. Sir is Executive Director of Dr. Shroff Charity Eye Hospital, New Delhi. He did fellowship in Cornea and Anti-segment at L.V. Prasad Eye Institute in Hyderabad. He has trained more than 200 long-term and short-term fellows in cornea anti-segment pathology and cataract surgery. He has founded the eye bank at SCEH, which is today among the leading eye banks in North India. Not only that, he's an accomplished surgeon and has even performed cataract surgery on the former President of India, Dr. APJ Abdul Kalam. Today, sir will be taking us on cornea grand rounds. Welcome to iFocus, sir. Over to you.
Thank you so much, Ankita. It's a pleasure to be here. And this is a wonderful medium through which we can connect. And can you see my slides?
Yes, sir.
Okay. So what we're going to do is take you through some clinical situations in cornea. And feel free to interrupt me and ask questions. And we'll try to run quickly so that we can cover more situations. Okay. So this is a situation, immediate post-op. Can one of the participants here, Dr. Rolika, can you tell me what
Yes,
this
sir.
would be?
So Rolika is a
Oh, sorry.
Arushi.
No,
Arushi.
Yeah.
Arushi.
Arushi, you there?
Yes, ma'am, I'm there.
Yeah, so what do you think this is?
So,
Looks like a strange cornea, right? Okay, let me give you,
edematous cornea.
right. And do you see an air bubble?
Yes, sir.
Yeah, so what do you think it could be? It's 1 day post-op.
Bullous keratosis.
No, so it's a surgery done for bullous keratopathy, which is 1 day post-op, where you see a lenticule here. So this is basically a dissect lenticule. You can see a temporal incision. And if you see the slit, you can see the lenticule as well. So this is basically a desmetstripic endothelial keratoplasty with an air bubble. You can still see the edema on it. Now, when would you do a surgery which is an endothelial keratoplasty? What would be the indications for surgery? So in India, the commonest indication would be pseudophakic or aphakic corneal edema. It could be traumatic surgery. It could even be because of TAS, and sometimes because of Descemet's membrane detachment. However, worldwide, if you see, the commonest indication for endothelial keratoplasty would be Fuchs endothelial dystrophy. But in India, you see Fuchs, but it's not as common as seen in Caucasian disease. The important thing to know about Fuchs is that it generally would be a bilateral condition. Usually after the 5th decade is when the patients present with corneal edema, or it could be just gutata that would be visible on slit lamp examination. A common indication, although we may not always operate for this condition, but causing corneal edema and endothelial decompensation would be HSV endothelitis. How do you differentiate? There would be a history of recurrence. There could be signs of recent or old inflammation with blood vessels on the cornea and corneal scarring, and it's usually unilateral. Posterior polymorphic dystrophy is one of the dystrophies where there's metaplasia of endothelial cells. Often the patient may be asymptomatic and glaucoma may be associated with it. And in children, you may have CHED, which is congenital hereditary endothelial dystrophy, which could be of type 1 or 2. Basically a very thick cornea, and depending on the condition, it could be very dense to not that dense. Now, when you examine a patient with on slit lamp, you may have stromal edema, but initial part, early part, you may have just, especially in Fuchs, you may have just guttate changes. And it's important to do a good specular reflection on slit lamp. And every ophthalmologist should know how to do it. You actually keep the optics at 30 degrees to the cornea as well as the light source. A practical way to do it is that you throw the light reflection on the cornea. You make it into a small, very small, the vertical height of the beam should be very small. Where you see the reflection, just behind that is where you look for the endothelium on high power. Specular microscopy, I think, is something that at least this much everybody should know. What do you measure? You measure the cell density, which is the number of cells in a unit area. For most adults, we would say somewhere between 2,200 to 3,000 cells we would consider as quite okay. Then it is not enough to just look at cell density. So we know all the endothelial cells need to be hexagonal. Once there is a problem with the endothelium, they start enlarging and they start changing their shape. And a very large cell, if there are more cells which are large, it's called polymegathism. And CV is the standard deviation in cell area by average cell area, and it should be normally less than 30%. Number of cells that are hexagonal is also measured, and they should normally be more than 60% of the cells should be hexagonal. So what is the advantage of endothelial keratoplasty over penetrating keratoplasty? So in a penetrating keratoplasty, you're putting more tissue, and so the risk of rejection becomes higher as compared to endothelial keratoplasty. In endothelial keratoplasty, the two popular choices today are DSEC and DMEC. In DMEC, you put only the Descemet's membrane with the endothelial cells, and so the chances of endothelial rejection is negligible. In DSEC, you do have rejection, but it's a little lower than that of penetrating keratoplasty. But the big advantage is that you do not get the problems of sutures and of astigmatism that you get with penetrating keratoplasty. And follow-ups become much easier. And so that's why DSEC and DMEC are becoming very popular choices. DMEC is a little more difficult surgery to perform with a learning curve. But that is, in DMEC, you can get a vision of 6x6. With DSEC, with some interface problems, you may have only up to about 6x9 vision. Of course, both these surgeries have a bit of learning curve. You may have complications of detachment of the graft, which may require rebubbling, more so with DMEC as compared to DSEC. Especially in the initial period of learning curve, you may have a lot of endothelial cell loss in the because of the surgical trauma. However, unlike a penetrating keratoplasty, there is initial loss, but then after the initial loss, the cell loss is almost similar to a normal atresia of the cells that happens. Of course, there is learning curve. Anterior segment OCT is useful for follow-ups to see whether there is interface fluid or detachment of a DMEC graft. Now let's look at another condition. And can one of you
sir, this is a
yeah, just describe what you're saying.
Sir, it is post-penetrating keratoplasty cornea,
Yes,
and
yes.
Interrupted sutures have been put, and so we
Right.
can see vascularization around, like in the inferior
Yes.
quadrant, and it might be.
Yeah, so and if you see, the vascularization is along the suture lines and crossing
Yes,
the host graft junction. And what else do you see?
Sir, the epithelium is taking up a stain at places.
Yes, some stain it's taking, but more, if you see this area, you can see this area is edematous.
Yes, sir.
And you can see almost an area of demarcation. Above that is relatively clear,
Yes,
and
sir.
below that is edematous. Not very clear in this picture, but there are KPs over here. Can you see some here? There's some
No.
KPs over here. We're not very clear in this picture.
Yes, sir, their evidence.
Yeah. So what do you think this is?
Sir, it is going towards rejection.
Yes. So this is an endothelial rejection. Whether this you would call as a, it's not clear, but if you saw just the KPs over here, you can see a demarcation line. And what is this line called?
Khoda
Khoda
dos line.
Right? So this is the
Yes,
Khoda dos line over here. And it's obvious what is the risk factor in this graft?
Sir, vascularization.
Vascularization. And normally, as soon as you see a blood vessel crossing the host graft junction or crossing along the suture like this, one should remove the suture because a suture is an inciting agent.
Factor. Okay.
So, and these sutures should have been removed earlier on. And a graft like this, one would, which is vascularized, one would keep a close follow-up on this patient, and you would need higher doses of topical steroids. So graft rejection is the commonest cause of graft failure. Up to 34% is because of that. And when do you use the term graft rejection? Graft rejection is an immune-mediated process, right? Graft failure could be the end point where any graft which gets edematous would be called a graft failure at the end, which is irreversible. But an acute immunological phenomena is what is called as graft rejection. So one should know these terms. When do you use the word rejection? Rejection, you use the term, generally it will be an acute condition, which is immune mediated. And the end point of that would become graft failure, which is irreversible. But graft failure would also be used for slow attrition of cells or a primary graft failure where the endothelial cells count was not good to start with. So these are two different terms. Graft failure is the end point where the graft has become edematous, but could be because of various reasons. But rejection should be used only when there's an immunological reason for it. Now, corneal grafting is among all the transplants in the body has the highest success rate because of its immune privilege. So there is relative non-recognition of allo antigens in the graft and destruction by the immune system. And this is most likely due to the absence of vascularity of the cornea, which doesn't allow the lymphatic vessels on the cornea. So generally our cornea is avascular, and that's why we have an immune privilege. And there is integrity of the blood ocular barrier, which also maintains this. I'm not going into the details, but something that you all should know is about ACADs, which is the anterior chamber associated immune deviations. So I'm not doing a whole lecture on graft rejection here, but one should at least know why the cornea has immune privilege. And of course, the most important reason is because of the avascular cornea and because of the integrity of the blood ocular barrier. But the ACAD is also an active immune mechanism which prevents rejection. Now, what are the risk factors for graft rejection? So they could be host factors, which is the most important. The most important, as we just discussed, is stromal vascularization, especially more than 2 quadrants of stromal vascularization, like over here, would be a risk factor. The best success you get in a graft is in the first attempt, when you do the first graft. Repeated grafts, basically, they would be pre-existing lymphocytotoxic antibodies, which make the graft prone for further rejection. Then conditions, especially common indication of a graft is herpes simplex keratitis, where you would have scarring on the graft. For herpes, the grafts don't do well, very high risk of recurrence as well as rejection. And some conditions like uveitis, atopic dermatitis also make the graft prone to rejection. If you've had a lot of inflammation in the eye and previous surgeries, anterior segment surgery, especially with vitreous in the anterior chamber or synecdoche, PAS formation, they also make the graft prone to rejection. So these are all the host factors. So every time we are posting a patient or somebody comes to us with a corneal scar, you have to see what is the risk of rejection and classify whether this patient is going to benefit from surgery or not. Then technical factors would be large grafts. If the grafts which reach up to the limbus would have a higher risk of rejection. And of course, suturing. Loose sutures and vascularized sutures make it prone to rejection. So if you have a vascularized host, you should always put interrupted sutures, because where it is vascularized will heal early and the suture will become loose. So that's to do with the follow-up. And then there are other factors like pregnancy, they say increases the risk of rejection. There's some interesting observations with COVID-19 as well. Recently, I had a patient, a doctor actually himself, and he had high markers with CRP and all the D dimers were high. And with that, he got a rejection in an otherwise quiet eye, which was doing well for the last 4 or 5 years. So treatment of graft rejection is largely topical steroids. So 1% prednisolone eye drop has to be given very frequently, and that is the mainstay of treatment. To top it, one could give IV methylprednisolone, at least one dose if the patient comes in the early part, but preferably 3 doses of 500 milligrams of IV methylprednisolone over 3 days. And the advantage is that you need a very high dose to inhibit the proliferating T lymphocytes. The role of oral steroids is not that much, because topical steroids act directly on the afferent pathway, and otherwise at the splenic level you need to work on the with IV methylprednisolone. Once this intensive treatment has been given, then one can also, if in a high-risk graft, put the patient on immunosuppressions like azathioprine. So any questions on that? So let's look at what, okay, yeah, any questions?
So till now we don't have any of the questions. So
Okay.
you can go ahead, or you can ask any of the hot seat participants also.
Right. So maybe we move to one more situation. Now,
Right,
can one volunteer to describe what you're seeing here?
Ajita, would you like to take that? Yeah.
Yes, ma'am. So the eye looks congested and there is hyphema with a corneal melt, sir.
Okay. Now, so hyphema, I can't see. Maybe what you're seeing is a little bit of hypopion, maybe. But congestion, yes.
Sorry, sir. I meant
so,
hypopenia.
Yeah. And yes, there is thinning. However, I would refrain to comment in a diffuse picture. For that, you will need a slit picture to see whether there is thinning. But you're right, there is a lot of thinning in this area. What else do you see? You see an epithelial defect, right? There is infiltration over here, stromal infiltration.
Yes,
right?
sir. Yes,
There's
sir.
probably thinning here and lot of vascularization, right?
Yes.
Anything else that you would like in history or?
History of any trauma history, sir?
Okay, so in this
Trauma.
case, no, there's no history of trauma. Anything else?
Any systemic disease, sir?
Like what?
Connective tissue disorder or something?
Connective tissue disorder like rheumatoid arthritis?
Arthritis, yes, or something like that.
So no, but why do you want to ask? What's the reason? It's a good point you've raised.
Oh.
Why did you think of that?
Sir, they can be associated with like corneal thinning and
yeah, so you could have sterile
in
melts.
PU.
Yes, you could have you could have PUK, which would be in the
Peripheral
periphery,
ulcerative, yes,
but
sir.
that would be in the periphery. But you could even get in the center sterile melts, which will also look to some extent like that, with or without infiltration, right? And
Yes,
you may, but that would be bilateral. Usually, something would be wrong in the other eye. If not a whole melt, they would be signs of dry eye, right? SPKs or something staining that you may often have with those cases. Anything else that you would like from the history?
So history of surgery or diabetes.
Okay, so no, maybe not.
Any
So-
source of infection in the body? Endogenous
Okay.
infection.
Yeah, so yes, these are all important questions. Whenever you see an ulcer, you would ask, but one or two other important questions we'll come to that you would like to ask. Now, you see a lot of vascularization, right?
yes, sir.
Now, which ulcers do you see a lot of vascularization? Would you see a lot of vascularization in a bacterial ulcer? A typical bacterial ulcer like Pseudomonas or Streptococcus or Staphylococcus? Generally not, because it will not give you that much time. They are acute ulcers, right? Vascularization is a sign of chronicity, or it is a sign of an ulcer being on the eye for a long time, weeks and months, right? Now, fungal ulcers can sometimes take a long time to heal, but do you see vascularization in fungus?
No, sir, usually not.
Usually
It
not.
will be.
It's one of the, when you start doing the difference between bacteria and fungus, well, in bacteria also typically, unless it's a very indolent bacteria like Mycobacterium or Nocardia and things like that, which are very slow, you don't see vascularization. And although fungus can sometimes take long time to heal, but it's not common to get vascularization in fungal ulcers. So which is the commonest way you get vascularization? What kind of ulcers you see vascularization? Any guess?
Pseudomonas.
Herpes.
Okay,
No,
herpes.
Pseudomonas is very, very acute. In 2 or 3 days' time, you may have melts in Pseudomonas. Pseudomonas doesn't give you time, right? It's a very acute condition. But herpetic ulcers are very common. Yes. So why?
Necrotizing.
So what should be, if you're thinking of necrotizing, what are the other questions you want to ask? Is there recurrence, right?
Yes, sir.
And so, of course, there is infiltration here, but so you would scrape and you get something non-specific like gram-positive cocci, which could also be a commensal. So you would ask for history of recurrence. Has the patient had any redness in the past, which lasted a couple of days, needing to go to a doctor? That would be something which you have to ask as a leading question.
Sir, use of topical steroids
Could be.
in past.
That is also often available. And but recurrence is something that you look out for. What is the other thing? When the patient, while you're talking to the patient, what do you see? You see a red eye, right? And you can see something white on the cornea. This would be visible even without a torch, right? However, you'll find the patient is sitting in your clinic very comfortably. He's not going like this. He's not really in spasm. He's not photophobic. What does that indicate? That the
Decreased
sensations,
sensation.
the corneal
Sensations have
sensations are
decreased.
decreased. So these are patients who have a history, long-standing. There would be history of recurrence, and you'll find the eye is open with a red eye and something white on the cornea. Even if they say they have pain, the pain is more due to uveitis, not because of the cornea problem. And so they may have ciliary tenderness, but they may not have that much of photophobia and spasm. So these are things to be seen. And so this patient was a case of HSV necrotizing stromal keratitis. And if you see the infiltrate is very white. If you look, of course, it's not visible in the picture. There will be no discharge. There's no slough, right? This is a very granular stromal infiltration with thinning. And why is it? What's the differential diagnosis of this condition? It's bacterial keratitis. The common things with bacterial are that there is, if you look at this, there is an epithelial defect, there is stromal infiltration, there is thinning. All these things can happen in a routine bacterial ulcer.
Yes,
What's
sir.
different? There is vascularization.
Vascularization.
There is lack of corneal sensations and lack of discharge and slough. This is a very granular whitish infiltration in the stroma. So this is stromal necrotizing keratitis, right? And you treat it with topical and systemic acyclovir. And often a lot of these patients may have an immune component with it. And after some time, you may sometimes need to add some low dose topical steroid. And eventually the patient heals with a scar, right? So we've already discussed this. The clue here is history of recurrence, pain, but no photophobia. Corneal sensations are decreased. There's minimal discharge and presence of vascularization, right? And so quickly, let's see how does HSV manifest. So there are broadly, this is the classification. There's congenital and neonatal ocular herpes. There's primary ocular herpes, and then the most common is recurrent ocular herpes. Now, the congenital ocular herpes, this is a patient that presented in the clinic, full-term normal delivery, and 5 days old. The patient actually was being treated for septicemia. And in the OPD, it looked like an opaque cornea, but there was congestion. So we took the patient up for EUA, and you find not only does the cornea take up stain, almost like a geographic stain, but even the conjunctiva had staining and like a geographic kind of ulcer. So this patient, they often have encephalopathy, and the patient can be very toxic. And if not treated in time, sometimes these babies can die. And they need systemic acyclovir. Babies get this infection from the birth canal. And generally what they say is herpes below the waist is because of HSV2, above the waist is HSV1. So normal, what you see as dendritic keratitis and stromal necrotizing, which we just discussed, is HSV1. But congenital and neonatal herpes is HSV2. And you may have manifestations as conjunctivitis, epithelial keratitis, stromal keratitis, even cataracts. But the important thing is that a lot of these children need ICUs for an IV acyclovir treatment. Then primary ocular herpes, a lot of us may have had, but it's innocuous. Very few actually reach up to a doctor. You just see some vesicles here and there. And most of the times the patient is asymptomatic. But 60% of the population by age 5 has been infected already. Most of us already have been infected. We all harbor the HSV virus. We are just fortunate that only some people manifest the disease. So HSV, primary HSV can present with these multiple dendrites, even on the conjunctiva. I've just seen a few patients of this. Most of the times it's self-limiting and the patient doesn't come to you. Now, the important is this classification of HSV recurrent keratitis. So you have the infectious epithelial keratitis, which can be just corneal vesicles, almost like SPKs, the dendritic ulcer, the geographic ulcer. Now, important thing in geographic ulcer is that these extensions are almost like dendrites, right? So when you stain, you'll see these extensions. Then you have marginal ulcers. Not very common, difficult to differentiate from blepharokeratoconjunctivitis. Then you have neurotrophic keratopathy, which is neither immune nor infected. This is a basement membrane problem where you have a punched out lesion, usually an oval, very clean base. And of course, the corneal sensations are absent here. If you leave them without treatment, they'll eventually perforate, where there'll be progressive thinning. And tarsorrhaphy is often required to help them heal. Then you have stromal keratitis, which has two main entities: the necrotizing stromal keratitis, which we just discussed, and the immune-mediated stromal keratitis. In the immune-mediated, you may often have no epithelial defect. There may be a stromal blood vessel around which there's some infiltration. This is immune-mediated. And then you have endothelitis, which is actually probably after dendritic ulcer, the next commonest is you see a condition like this where the patient presents with stromal edema. If it's a lot of edema, you sometimes are not able to see the KPs, but just behind that, you'll find they are keratic precipitates. It could be disciform, linear, or diffuse. You could have trabeculitis, so oftentimes you may have raised pressure, and you may have uveitis. Now, there have been very important landmark studies which every ophthalmologist should know is the HEADS study, the HEADS 1 and the HEADS 2. Try to read them. Very badly written articles, difficult to understand. I'll just try to give a gist of it. HEADS 1 was basically trying to evaluate the efficacy of topical steroids in treatment of stromal keratitis with topical trifluridine. Now in the US, they don't get acyclovir, so they use trifluridine topically, but you can replace with topical acyclovir, which actually works better than this. Efficacy of oral acyclovir in treatment of stromal keratitis and efficacy of oral cyclovir in treatment of iridocyclitis. So these were the three questions they had in HSV-1. And the study showed that use of topical steroids was useful in resolving stromal keratitis faster and with fewer treatment failures. Now, the thing that you have to take with a pinch of salt is in that time, endothelitis was classified as stromal keratitis, and most of their patients were actually of endothelitis. They did not have enough patients recruited for stromal necrotizing keratitis. So when we are talking of prednisolone drops, it is largely the endothelitis and immune-mediated stromal keratitis. But even if you didn't use, the patient would resolve, but it would take longer. There was no apparent benefit of adding oral acyclovir to the treatment when we were treating stromal keratitis. So if you have endothelitis, it's largely an immune-mediated condition, and topical steroids is adequate. Oral acyclovir in the treatment was not found to have any additional benefit. The HEADS 2 study wanted to determine whether early treatment with oral acyclovir in treatment of epithelial disease prevents progression to stromal keratitis, and efficacy of low dose oral acyclovir in preventing recurrent HSV. So does oral acyclovir prevent recurrences? The last bit of what are the risk factors, the study never was able to complete this. Now, in epithelial disease, in the treatment of acute HSV epithelial keratitis, which is largely a geographic ulcer and dendritic ulcer, there was no benefit from additional treatment of oral acyclovir. So topical antiviral is enough to treat geographic ulcers and dendritic ulcers. There is no benefit of oral acyclovir. Now, this is the important part. For prevention of recurrences, if you give 400 milligrams oral acyclovir twice a day, it found that it reduced by 41%, which is quite significant, the risk of recurrence. So oral acyclovir 400 milligram twice a day reduces the risk of recurrences by 41%. So we know the problem of HSV is that it recurs. 9.6% at 1 year, 22.9% at 2 years, 36% by 5 years. So and by 20 years, almost 60% of the patients would have had some recurrences. So with each passing year, there are more recurrences. Each time you have a recurrence, there would be scarring and leaves the eye with more morbidity. So oral acyclovir reduces that risk of recurrence. So if you look at this patient, what would you call it? Anyone?
Ajiba, would you like to take
Geographic.
that?
So, geographic ulcer with a terminal bulb.
Yeah. So why is it not neurotrophic?
So neurotrophic will have more of a punched out ulcer.
Right.
It has
So
a
that,
leading edge.
yeah. So it'll be punched out. You won't have these, extensions with terminal bulbs. What is common between the two?
The staining, sir.
Okay, both have an epithelial defect. Okay. What is common? They must be having something common. That's why I asked to differentiate, right? So both have poor sensations, right? Both have etiology of HSV. Of course, you can have other causes of neurotrophic too, but common etiology is HSV. So you sometimes have to differentiate a geographic ulcer from a neurotrophic ulcer because there's a difference in the treatment. A geographic ulcer requires intensive topical antiviral therapy, while the intensive therapy may be detrimental to healing because of the toxicity of the drug in a neurotrophic ulcer. So it's important to differentiate the two. So this is a geographic ulcer. You start the patient with topical acyclovir, and you find initially the first thing that starts happening is these terminal bulbs start blunting, right? This is how it will start healing. And it basically heals with a scar. And you think that that's the end of the story. However, if you look closely, there's an epi defect which is not healing for 2 weeks. And here it's a clean base and slightly punched out. So what is happening here now?
So toxicity because of antivirals.
It could
epithelial.
be that, and there is now a neurotrophic kind of a defect there.
Yes, sir.
Right? So to help it heal, why do you give lubricants? Why do we give a lot of lubricants in a neurotrophic ulcer? Can anybody help me answer that?
So it prevents from, it keeps the surface moist so that with each blink, the eyelid don't rub against the cornea.
Sir, washing off of all the
Okay, so let me give you a statement. Let me give you a statement. Corneal anesthesia is the worst form of dry eye. Why? Because the afferent limb of the tear reflex doesn't work, right? So I'll give a homework to most of the PGs. Go back to your anatomy class and draw the reflex, tear reflex. What is the afferent and what is the efferent nerve? I'm not discussing it here, right? Because the corneal sensations are required.
So,
Yeah.
so actually, the terminal ends of the nerves are exposed, so they are constantly irritated.
No, here they are basically blunted. There are no sensations. So because the afferent limb of the tear reflex is not working, there is no reflex to tear. And so these eyes are actually very dry. And so you need to supplement them. And also we like to do a tarsorrhaphy.
Tarsorrhaphy.
And tarsorrhaphy, how does it work? Well, exact mechanism we don't know, but it helps in providing trophic sensations. Also, it reduces the, what you just mentioned by the movement of the lids, the erosions are reduced. Also, it prevents dryness because it reduces the palpebral aperture. So there are several mechanisms, but most likely I think it is to do with the trophic sensations which the nerves from the lids probably help in healing. So tarsorrhaphy is magical. That you'll find that within about 3 days, the ulcer starts healing. And you should have a low threshold. And so with the tarsorrhaphy, this patient healed. However, presents again after a few days with this infiltration in the stroma and the small epi defect. And now there is a stromal disease, right? With these blood vessels. And eventually the patient heals with oral and acyclovir as well as even some topical steroids. So sequelae of HSV are very common with stromal disease. And so these patients keep coming back to you in the clinic. So oral acyclovir is given in immunocompromised patients. You give it in uveitis because active virus has been found in uveitis. It can be given in infants who may not be compliant with the topical treatment and sometimes in significant primary HSV. And of course, we give oral acyclovir for prophylaxis. And whenever you do a keratoplasty for an HSV scar, you need to give oral acyclovir. The problem is when to stop because the effect of oral acyclovir lasts only for the time that the patient is having oral acyclovir. So if I have a one-eyed patient where I've done a corneal transplantation, I might give it lifelong. If it's a one-eyed patient who's having recurrences, again, I'll give it for a very long period of time because otherwise the recurrence will come in. Is there any toxicity of oral acyclovir? What do you get tested every few months? Anybody?
The liver function test.
No, it's kidney function. So you must get the KFT done, say every 3 months for patients who are on oral acyclovir. Otherwise, generally a very safe drug. So one last bit on HSV, which are the places where you have live virus? So dendritic geographic ulcers have live virus, and so you give topical acyclovir. There wasn't any benefit of oral acyclovir as we saw in the head study. These will be treated with topical acyclovir. Head study did not comment on stromal necrotizing keratitis, but our group at Shroff, we did a study and it's published that oral acyclovir and topical acyclovir had a benefit in treating stromal necrotizing keratitis, and it makes sense because there's live virus there. The uveitis also has live virus, and head study showed that uveitis, there was a trend towards an improvement with acyclovir, but they could not prove it. While an endothelitis is an immune mediated, and so there was no statistical benefit of oral acyclovir. Again, neurotrophic again is non-immune, non-infective, so there's no role of, in the treatment, there's no role of topical or oral acyclovir. You may give it for prophylaxis, that's different, but not for treatment. Okay, now how's the time? We have 15 minutes. Okay. Any questions?
So we do have some questions online. Would you like to answer them, or you would like to take them in the answer?
I can answer them. Maybe one question right now.
Okay, sir. So the question is done on HSV endothelitis, sir. That till what time we can suspect corneal edema due to HSV endothelitis post-operatively after a cataract surgery?
After a cataract surgery. So endothelitis, there would be signs of endothelitis, most likely of some kind of recurrence. The patient may have corneal scars, may have corneal blood vessels, or may have old pigments before you attempted the cataract surgery. It's very unlikely that the very first episode has happened immediately after surgery. Not very common. It would be quite a coincidence. So you would see signs of, or you may have missed those signs. So if there is, otherwise also the treatment for endothelitis is topical steroids, which you would be giving with a cataract surgery. But if somebody is not improving, for generally you would, try steroid therapy and allow the endothelial to heal itself for up to 3 months. Usually you would not jump into doing a corneal transplantation or desect before 3 months of any cataract surgery. You would allow that much time for it to heal.
Right, sir.
Right?
Thank you for answering that, yes.
Okay. So I go to shift gears now to another condition. So this is a 21-year-old male with blurred vision and very simple kind of astigmatism that we see. Slit lamp examination generally looks normal. The patient wants to get rid of glasses and subject the patient to a topography, and this is a Placido-based topography, and you see the steep area indicating keratoconus. And there are these different indices. So this is the Kiza index. There may be some machines have Rabinowitz, and there's Kleist-Meeder. These are different indices which they've put algorithms in the machine that help you with the diagnosis or suspicion of keratoconus. The most important, of course, is superior-inferior asymmetry in keratoconus. So if there is a 0.3 millimeter above and 3 millimeter below, what is the difference in K reading? So in keratoconus, it'll be skewed. Like this area is steep, this is flat. And so there will be a lot of asymmetry. It could be at 3 millimeter zone, at 5 millimeter zone. So normally you should expect less than 1.5 diopter difference between at 3 millimeter and less than 2.5 diopter at 5 millimeter zone. So what is the diagnosis? Did we miss something on slit lamp? Or is it forme fruste keratoconus? So if you have no clinical signs on slit lamp, you refer it to as subclinical or forme fruste keratoconus, which you've picked up only on topography. So just quickly, I'll run through what are the different signs of keratoconus that you have, because this is important for as a question in your examiner may ask. And also in the clinic today, keratoconus has become a very important diagnosis because of refractive surgery. So one of the most important signs is scissoring reflex on retinoscopy that you see. So I hope today residents learn retinoscopy, because a lot of places I'm seeing it has given up and it's only optometrists who do that. So I hope all of you learn how to do retinoscopy. And if you see scissoring reflex, that's you see this in almost, even in very mild cases. On slit lamp, the pathognomonic sign of keratoconus is Vogt striae. These are these vertical stress lines in the stroma, and if you press on it, they disappear. So this is the pathognomonic sign. If you see Vogt striae, That's the gold standard that you made the diagnosis of keratoconus. You may have Flesher's ring, as you can see here, which is an iron deposit at the base of the cone, better seen with cobalt filter. So this is the Flesher's ring. Apical scarring is seen in moderate to severe cases, almost 20% of the cases. And sometimes the use of contact lens also increases this apical scarring. This is at the cone. Then in very advanced cases, you may have splitting of the Descemet's membrane, allowing fluid to go in. This is an acute condition called high drops. You may have, this is also quite commonly seen as prominent corneal nerves. Probably it's because the collagen is different and makes the nerves visible. In very severe cases, you have Munson's sign. Quite frankly, most of the time when people ask, they start with Munson's sign. If you are starting with torchlight examination, it's okay to say, but otherwise, if you're talking in terms of severity, Munson's sign would be seen only in very advanced cases where there's a V-shaped deformity of the lid because the cone, if you ask the patient to look down, and the Risworti's sign, where you throw a light from one side and you'll see this lateral illumination of the cornea on the temporal side. So it'll be good that you know all these. And of course, in dilated pupil, you'll have this oil droplet sign, also called as Charlot's sign, which is a dark reflex in the area of the cone. So all of you must know all these signs. They could be asked in any of the vivas. What are the diagnostic modalities? You could do a topography, which would be a Placido disc based, which you've already seen. But the more common and better modalities are today that you should also evaluate the back surface elevation, which can be measured either with an OP scan, which is a scanning slit device. But today the gold standard is Pentacam, which is a Schlemm imaging device. I'm not going to be discussing this, all these pentacams, but I think you've already, or you're having a lecture on ectasias, I'm sure it'll get covered there. But nothing to be scared of. This is the quad map, which would have the pachymetry map, the anterior float, and you would have the posterior float. And there are red flags and the Bellin-Ambrosio curve. Also these green, yellow, and red tell you what is the risk of ectasia. OCT is again a very good modality. So some clinics may not have a topographer, but may have an OCT. So anterior segment OCT pachymetry maps are actually very accurate. And the newer OCTs actually measure in different meridians. And you can have a keratoconus software in it, which also picks up with the superior inferior asymmetry on pachymetry keratoconus quite early. So OCT is again a very good modality for picking up keratoconus. On the management, we have two things to look at. One is prevention of progression, and the other is visual rehabilitation. So collagen cross-linking is today very commonly performed, where you have UV radiation and riboflavin mix, where there's release of oxygen radicals, which causes the strengthening of the cornea. So these are the cross-linking which become more cross-linked. And so when should you do it? Cross-linking should be done when you have documentation of progression. But because we know that keratoconus relentlessly progresses in the teenage period, so if you see any teenager with keratoconus, there's no need to have a documented evidence. You can even put that patient for cross-linking because it will for sure progress. But if you have somebody in mid-20s or 30s, you should have documented evidence to see that it is still progressing. Now, important thing to remember is keratoconus is not really a surgical management. The first line of treatment is, of course, if the patient is happy with glasses and cylindrical numbers, that's fine. If the patient is not happy with vision, then the best quality of vision will come with rigid contact lenses, which could be RGPs, it could be the special row scale lenses which are designed for keratoconus, and the scleral contact lenses. Scleral contact lenses are large lenses that rest on the sclera, and they have a fluid that you put in the reservoir and put it on the eye. It's like a liquid bandage, very comfortable and gives very good vision. So keratoconus largely should be managed by contact lenses. It is not a surgical disease. For mild to moderate cases, you could use Intacs or PRK with CXL. Also is being trying to shift the cone to get slightly better vision with either soft lens or with spectacles. Some people like to put ICL, but it doesn't give very good quality of vision because the irregularity on the corneal surface does not get corrected with ICL. In advanced cases, one has to do a corneal transplantation, and especially in patients who have had keratoconus very early or very steep, they need surgery. Penetrating keratoplasty has very good results, over 90% survival in PK, very low risk of rejection. But the surgery that today is done is deep anterior lamellar keratoplasty, where the patient's endothelium is retained. You do a lamellar dissection. There are different techniques of doing that with air bubble, and you go down up to the Descemet's membrane and replace only the anterior stroma. By doing that, you reduce the risk of immune rejection, endothelial immune rejection, and so the longevity of the graft is much better. It's an extraocular procedure, so risk of glaucomas and cataract formation and also the need for topical steroids for a long duration reduces. However, the bugbear is astigmatism. That problem continues as is with a penetrating keratoplasty. So important thing to remember is advise surgery only when the patient is intolerant to contact lens or does not improve with contact lens. How are we doing on time? I think we are pretty much there. So let's take a few questions. I won't go further.
Okay, sir. So the one question is that, please tell what is the difference between stromal infiltration and stromal abscess? I think they just want you to highlight it once again.
Yeah, so stromal infiltration, infiltration when you use the term is basically WBC leukocytic infiltration, right? Which will happen with any kind of inflammation, be it with infection or without infection. So when you have a viral keratitis, there is a big component of immune mediated inflammation, which is what I'm saying is infiltration, which is largely the leukocytes. When you have a bacterial ulcer, you also have a component of infection, which can be called as abscess. So which is more dense, usually very yellowish, and it will not be uniform. You'll have patches where it is more dense and areas where there's less dense. And around it is where you'll find edema. Edema is, again, if you see histologically, would be leukocytes. In this viral infiltration where I mentioned, you'll find it's very whitish. It's not very yellow, more uniform, very granular kind of things, which is more of leukocytic infiltration.
Right.
Any more questions there?
Sir, I have a doubt, sir.
Yeah.
Sir, if like in neurotrophic ulcer, if HSV is the cause of the neurotrophic ulcer, the mode of treatment should point towards HSV, sir.
So there are two things. One is to prevent recurrence, and the other is to treat the ulcer when it is there. So in treatment of neurotrophic keratitis, the more topical drops you give, there will be more toxicity and the healing will be retarded. So you want to withhold your topical acyclovir when you're managing a neurotrophic ulcer, you have to have minimal medication, only lubrication. If you want to prevent HSV to recur, you may give oral acyclovir in a prophylactic dose of 400 BD, but that is not to take care of the condition at that point. It is largely for prophylaxis. So neurotrophic ulcers, neurotrophic ulcers should be best managed with a tarsorrhaphy and a lot of lubrication. Some people may use amniotic membrane, and there are studies that have shown similar kind of results with both. But you could use either of the modalities.
Yes, sir. So there's another question about neurotrophic ulcers, that is like, please tell about reverse staining. So, and do all neurotrophic ulcers have reverse staining pattern?
So they may, but actually it's very classical. If you ask me, I don't like to stain ulcers, because when you stain an ulcer, you lose all morphology. You can't differentiate whether it's a clean base or is it an infiltration in the stroma. I would stain an ulcer only when I'm not very sure is there an epithelial defect or not, and that is when I've seen the patient properly, and only at the end I might stain it. So there is a tendency that you stain an ulcer quickly. As soon as you see an ulcer, you stain it. But by staining, you actually lose a lot of morphology that you wanted to see. And sometimes if you are seeing the patient after, say, 10-15 minutes, you'll find even the aqueous has gone green. And it becomes very difficult to, see what is happening in the eyes. So you're right in saying there's this reverse staining that happens, but it's not the most important thing to differentiate this.
Okay, sir. So there's another question that how do we diagnose HSV uveitis or trabeculitis clinically, and what's the need of oral acyclovir in such patients?
Yeah, so it's a good question. One is that if you see scars on the cornea, and it may not be even active at that time with uveitis, always suspect that to be HSV. So a corneal condition with uveitis, I would always suspect HSV. HSV, uveitis, I think a lot of uveitis we label as idiopathic, but the way we see recurrences on the cornea, I think some people get just recurrences of uveitis. So there is the only way, sure way of telling whether it is HSV is that if you take an AC tap and subject it to PCR HSV, and you get that positive, that'll be something that would clinch the diagnosis. But in a mild uveitis, you often don't want to do that. But the way to, but clinically, if you see corneal scars or corneal pathology with uveitis, suspected to be HSV. If you have iris atrophy patches, again, that's a sign of HSV. Both zoster and uveitis can have atrophy of the iris. Now, the treatment, basically, live virus has been grown in uveitis. And so you should treat these patients with oral acyclovir. And the treatment dosage would be 400 milligrams 5 times, along with the topical steroids.
Yes, sir.
And
So
I think we often don't take pressures in these patients because if there's some corneal staining or something, but very often the pressures are high and that needs to be medically managed.
Okay, so that brings us to the end of the session today. Thank you so much, sir, for orienting us to all the possible case scenarios related to cornea. It was actually great. In fact, I wish I had it before my exams. Thank you so much.
We had it in iFocus, but you are missing, Rolika. Thank you, Umang.
Thank you so much. It was a pleasure.
Job.
Thank you.
Thank you so much. Good night.
Thank you. Good night.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.
Thank
Bye.
you, sir.